K9, or given the recent onset of his diabetes that is diet controlled and no history of cardiovascular disease, there's no rationale from changing from pravastatin 20 or recommend changing to atorvastatin 40. Okay, great. Most of you are choosing the correct answer of atorvastatin 40. And we'll go over why that is in the next couple slides. So, as I mentioned, a moderate intensity statin is recommended for all people with diabetes. So moderate intensity statin are those in the middle there that lower LDL by 30 to 49%. So rosuvastatin 5 to 10 is in there, atorvastatin 10 to 20 is a moderate intensity, as well as simvastatin 20 to 40. So if the ASCVD risk is over 7.5, then a high intensity statin is recommended. Because a high-intensity statin lowers LDL by over 50%. And there's only two statins, atorvastatin and rosuvastatin, that are considered high-intensity statins. So pravastatin is in that lowest intensity area, and these statins only lower LDL by less than 30%, so not that potent. And given the patient's age and risk factors, his estimated risk would be more than 7.5%, so would recommend using a high-intensity statin. We go to PCSK9s only when high-dose statin therapy is unable to achieve the LDL goals. And again, for very high-risk patients, the LDL goal is 50, and for high-risk patients, the LDL goal is 70. And omega-3s would not be chosen here because although they increase HDL and lower VLDL, all of the outcomes trials have shown that statins improve cardiovascular outcomes. Unfortunately, we don't have great studies now of decreasing triglycerides that show that it improves cardiovascular outcomes. And ezetimibe should be used as an add-on therapy for those who are unable to achieve LDL goals on maximally tolerated statin therapy. So ezetimibe might be required, but we should first try the atorvastatin 40. So in summary, for statin intolerance, this is defined as one or more adverse effects associated with statin use. Most often, this is statin-associated musculoskeletal symptoms, SAMS. This usually resolves with dose reduction or discontinuation of the statin. And we must try at least 2 statins at the lowest approved daily dose before we sort of label the patient as having statin intolerance. I find it that in my practice, because we are required to tell patients about what side effects that they may have, that we have a nocebo effect, which is the opposite of a placebo effect. Placebo means that people think good things will happen when they take treatments. Nocebo means that they think they will have adverse effects from the treatments. And often when people look things up on Google or ChatGPT or Perplexity, they're finding these musculoskeletal symptoms, and then they come back and tell you about them. So when you find people with complete intolerance after you've already tried 2 statins, that's when you consider non-statin therapies like ezetimibe, like PCSK9s, like bempedoic acid, like inclisiran. And for those who may be able to have partial intolerance to statins, you can consider every other day dosing because statins have such a long half-life, or adjunctive non-statin therapies like ezetimibe or bempedoic acid. So with that, I will conclude my comments and looking forward to your questions.
Now the floor is open for the questions. Is there any questions from any delegates?
Hello? Hello, thank you for the nice presentation. Just a quick comment on that. The problem that the unusability of the bempedoic and ezetimibe in our country is the lack of the availability because it is not registered in our DDA. We have been fighting a lot from the Cardiac Society as well as from the Society of Internal Medicine for this registration. Since we have got a combination of rosuvastatin and ezetimibe, 10 mg combination, sometimes it's hard, so we have to use 30 mg of 40 mg of rosuvastatin with 20 mg, 10 mg, and 10 mg rosuvastatin and ezetimibe combination we are using in this patient with Hododa for the secondary prevention in patient with the high-risk patient. That's the major problem. My one question is so regarding the statin tolerance, I see guidelines, some the European, some Indian guidelines, they're mentioning the rise in the creatine phosphokinase level when you have a pain in the muscle aches in patient receiving the statin. They have mentioned 4 times the upper limit of normal, but the American has measured 3 times the upper limit of normal. So there is quite a little bit discrepancy in the upper limit of normal in the CPK level. Can you highlight on this?
Absolutely. So thank you for your question. The first part of your question concerned combination therapies, which I understand are widely available, and you may choose to start a patient on a combination therapy immediately from the get-go, and that is not the wrong answer or the wrong thing to do. And in the next talk, I'll talk about the efficacy of doubling a statin dose versus adding on another drug. And adding on another drug actually gives you much more LDL lowering. So I agree with that approach. It's just not how the guidelines are written, but the guidelines are just guidelines. You as a clinician ultimately make the decision on what the best drug is for your patient. And then in terms of the upper limit of normal on a cliff at 3 times the upper limit of normal or 4 times the upper limit of normal. The risk is getting worse, and we've just decided where to put a threshold on. So my answer to that is we have to take into account the clinical context and make your decision based on that. Thank you for your question.
Again, I am coming to this. My question is pregnant lady with dyslipidemia. As you see, statin is contraindicated. How to manage those cases?
So that's a great question, and I will go back to the graph in which I showed it's really the cumulative dose of LDL, and fortunately, pregnancy is only 9 months long, and it is a pregnancy class X, and the reason that statins are pregnancy class X is because they are HMG-CoA reductase inhibitors, and we need cholesterol to insulate nerves. And in a growing fetus, cholesterol is needed. So during the time of pregnancy, and I've taken care of pregnant women, and when they have familial hypercholesterolemia, and they want to get pregnant, let's say, I just say, look, we're not even going to check your cholesterol for 5 years that you're going to have kids. It's okay. We treated it before. You know, we'll just not check because they get very, a lot of stress when they see the numbers during pregnancy and childbearing. So just don't check during those years.
So what is the use regarding bile sequestrant? Use of bile sequestrant in case of pregnancy.
So the question was use a bile sequestrant, which is a great choice. And in the next talk, I'll show the timeline that bile acid sequestrants have been around as long as I've been alive. They're great drugs to lower cholesterol, one of the first drugs that we had. Unfortunately, there's no cardiovascular outcomes data on bile acid sequestrants, and they're very difficult to take.
Next question, John.
I have one query.
Yes.
So
Another
metabolic syndrome being more prevalent in our part of world, so we get mixed dyslipidemias, both with high triglycerides and high LDL. So how do you think is a better approach to handle these sort of patients?
Okay, great question. I'll restate it. People with metabolic syndrome, high triglycerides, low HDL, which is quite common in South Asian patients. All of you are taking care of this. And I'll also say that we've recently added kidney markers to metabolic syndrome. So I was on the cardio-kidney metabolic syndrome new guidelines. So it's all the same as metabolic syndrome. We've just added EGFR and urine microalbumin to that. And in terms of treatment of that, I would aim for the same LDL targets, but use a non-HDL target. So non-HDL is total cholesterol minus HDL. That's non-HDL. And so you just add 30 onto those targets. So instead of 70 of LDL, go to 100 of non-HDL. So non-HDL is just total cholesterol minus HDL. I'll just remind us all that total cholesterol by the Friedewald formula, total cholesterol equals HDL plus LDL plus VLDL divided by 5, which is triglycerides. And we used to calculate LDL by measuring total cholesterol, by measuring HDL, and by measuring VLDL, and we divided by that by 5. And just by algebra, we got a calculated LDL. Now we can directly measure LDL. But for your patients with high triglycerides and low HDL, triglycerides are still considered atherogenic particles. So go for non-HDL targets of 100 to 80, basically, 80 to 100.
And the medications you put on the board for it? Statins, other than statins, would you like to combine fenofibrate with it? Or would you like to add eicosapent pentathoic acid?
I would love to do studies on that.
Thank you.
I think there is no other question from the floor. Maybe we can move forward.
Thank you. That was a very interactive session. I think we'll move on to next session. I would like to invite again Dr. Naveen Rajgopalan. He will be talking about improving the management of hospitalized patients with heart failure. Dr. Naveen.
Thank you. Thank you. Before I get to my presentation, I want to answer the question that was asked during my presentation about the when patient has peripartum cardiomyopathy and wants to continue breastfeeding, what agents are safe. So the most experience showing safety to in the lactation of the infant would be long-acting metoprolol, enalapril, and spironolactone. So there's no really experience with ARNIs and/or SGLT2 inhibitors. So I actually got the consult of one of my pharmacists at UK. Actually, the hospital I work at has a very good pharmacy program. Actually, Dr. Mukherjee and I worked together. He was previously at my institution, and we were actually reminiscing about how we have a pharmacist we can call all the time. So I was able to phone a friend from here in Nepal because it's 9 a.m. in the US. So I'm happy to answer that question. So now I want to shift gears from my earlier talk and talk about patients who are hospitalized with heart failure and how we can improve management of those patients. So first I'll discuss strategies to improve diuresis in patients with decompensated heart failure, talk about the benefits of utilizing GDMT during heart failure hospitalization and how we can recognize patients with cardiogenic shock and the role of invasive hemodynamics. So one of the things you'll notice during my talk is that the data is less robust with hospitalized patients, and also a lot of the data I'll show you combines systolic heart failure or reduced ejection fraction and HFpEF, heart failure with preserved ejection fraction. So both those patient populations are looked at in the data that I'm going to present. So I believe I have 2 or 3 questions in my talk today with the audience response system. So the first one we'll talk now. So a 68-year-old male is admitted to the hospital with worsening shortness of breath with signs of volume overload. He has edema of his legs and abdominal distension. He has known heart failure with preserved ejection fraction, also called HFpEF, felt to be secondary to long-standing hypertension. He admits to dietary noncompliance due to family visiting for the holidays. His home medications include furosemide 80 milligrams BID, sacubitril valsartan, and empagliflozin. Creatinine is 1.5, was 1.3 1 month ago, and his NT-proBNP is elevated. What is your starting dose of intravenous Lasix? A, furosemide 40 milligram IV BID, B, furosemide 80 milligram IV once a day, C, furosemide 120 milligram IV BID, or bumetanide 1 milligram IV BID. You can show the QR code. Give you a few moments to answer that. So this patient has heart failure with preserved ejection fraction coming in, volume overloaded, creatinine of 1.5. The important point is that he at home takes furosemide 80 milligrams twice a day. Okay, we'll close it up. Okay, so most of you chose furosemide 120 milligram IV BID. So again, like before, I'm not going to tell you what I think is the best answer until we go through a few slides. So one of the problems that we know about in the United States, and imagine it's the case around the world, is that when patients are volume overloaded and they come into the hospital, we don't do a good job of getting rid of fluid. So this is some data that looked at the changes in body weight when patients were admitted to the hospital, and the change in body weight was rather modest, only about 2 kilograms. And most importantly, a quarter of patients actually had no weight loss or even had weight gain during hospitalization. And the reason this is important is for multiple reasons. Number one, if patients leave the hospital still fluid overloaded, they may get readmitted. Number two, congestion is actually felt to be an adverse prognostic sign in heart failure, and it can lead to the onset of cardiorenal syndrome. And then patients may get discouraged. They may not want to see a physician and follow up. May say, what's the point of coming in the hospital? I come in and I don't feel that much better when I leave the hospital. So here's a diagnostic algorithm for acute decompensated heart failure that I want to highlight. And the first step is the first question to ask as we try to diurese patients is, are they on a loop diuretic at home? So if they're a new diagnosis or not on a loop diuretic, you can give them 20 or 40 milligrams IV of furosemide and see what their response is. If they are on a loop diuretic, you should give as an initial dose 1 to 2 times the daily dose intravenously that they were taking orally. And actually, I'm going to show this algorithm a little bit later in the talk, so don't pay attention yet to what is written below that. So the optimal dose and administration of diuretics has been studied, although it's difficult to study in many trials. But there was one of the more famous trials that was published was called DOSE, published in the New England Journal of Medicine back in 2011. This was a randomized trial of IV furosemide in hospitalized patients. Again, only 300 patients, and they dosed this in two different ways: bolus or continuous. But also the dose was also 2 different ways: low dose, which was the patient's oral dose at home, versus high dose, which was 2.5 times their oral dose at home. And what they found was there was really no difference in any clinical endpoint. One of the things they wanted to look at was renal function. So on the left, you see that there was a slightly increased creatinine in continuous versus bolus, also a slightly increase with high dose versus low dose, but this did not reach statistical significance. So there was no renal impairment with the high dose versus low dose. On the right, you see actually some clinical outcomes. This was looking at heart failure rehospitalization or cardiovascular death out to 2 months. And there was no difference with continuous infusion versus bolus infusion or low dose versus high dose. So many of us have been thinking over the last, before this trial was published, that continuous dose is safer. You get more fluid off, it's easier on the kidneys, and this really did not show that to be the case. Really, it was left up to the practicing provider if you wanted to use bolus therapy or continuous infusion. Another trial that looked at this, which was called ROPA-DOPE trial, which was a randomized trial in hospitalized patients. They had once again compared bolus furosemide versus continuous infusion. They also looked at the role of dopamine. The daily diuretic dose was 2 times the patient's oral dose, and they did not have a low dose group. So everybody got 2 times the oral dose, either continuous or as a bolus. And once again, the hard clinical endpoints were not different, but surprisingly, patients with continuous infusion actually did have a statistically higher change in creatinine at 72 hours. So there was some renal impairment seen with the continuous infusion, and there was no significant benefit. So people didn't diurese anymore with continuous infusion. So really all the clinical endpoints were neutral. The one thing I didn't mention was dopamine. Dopamine also did not have any benefit. So people in the past have looked at renal dose dopamine, maybe that can augment diuresis, and this was kind of the nail in the coffin with that. There's really no role for renal dose dopamine to augment diuresis. So some take-home points: there is no advantage to utilizing a continuous IV diuretic therapy or bolus therapy, but even though I showed that there was no detriment to low-dose therapy, the guidelines really state that we should be doing a better job of diuresing patients, and the initial dose should be 1 to 2 times the previous home dose. So we should not be giving patients quote-unquote low-dose diuretics when they come in the hospital. Our goal should be to diurese people quickly and effectively as soon as they come into the hospital. Single-dose administration is discouraged due to the possibility of post-dosing sodium retention. And of course, patients need to reassess regularly. The worst thing you can do is give a patient a dose of a diuretic and check on them the next day. If you have team members or tell the nurse to call you, basically look at how they're doing 6 hours later. So if you look at the question, the patient takes 80 twice a day of furosemide at home. The guidelines state we should give at least 80 to 120 IV BID to give them the adequate diuresis. So the correct answer is C, which most of you chose. Actually, I kind of chose this to be a little difficult because I want, many of us would not do 120 IV BID, but congratulations, you chose that answer. And when I gave this talk previously, most people chose 40 BID. Because if we even look in the United States in registries, if patients are on a high dose at home, we don't do a very good job of giving them effective diuretics because we're gun shy. We're like, oh, 120 is too much. But we should not then be surprised if we give 40 IV and then nothing happens. We have to give patients a high-dose diuretic. For those of you that are not familiar with the conversions, bumetanide 1 milligram is equivalent to 40 milligrams. So 1 IV BID would not be the right answer. If I had picked 2 IV BID, that could have been a plausible answer. So one of the things I also hear is, well, maybe let's not give a high-dose loop diuretic. Let's add a thiazide diuretic. Like in the US, we give metolazone, or the intravenous form is Diarel. And I'm not going to show the data. I just want to show what's written in the ACC guidelines. But thiazide diuretics have been associated in some studies with rates of electrolyte abnormalities, which in heart failure patients can lead to arrhythmia and adverse events, mainly hypokalemia. We all get concerned about hyperkalemia, but in many trials, hypokalemia is actually more of an adverse event than having slightly high potassium. So in the ACC guidelines, they say, if you look at number 2, for patients with heart failure and congestive symptoms, addition of a thiazide to treatment of the loop should be reserved for patients who do not respond to moderate or high-dose loop diuretics. So we should not be just giving patients a thiazide up front without trying at least moderate or high-dose loop diuretics. So in the previous case, if I had selected give 40 IV of furosemide plus a thiazide, that also would not be the right answer. I added this slide 2 talks ago because a person in the audience asked me about tolvaptan. So for those of you who may be aware, tolvaptan, or not aware, tolvaptan is a vasopressin receptor antagonist that can increase sodium retention in heart failure patients with hyponatremia. Does anybody know the name of the trial where tolvaptan was studied in heart failure? Yeah, so Everest. So I mentioned that here, but maybe I shouldn't have mentioned that because yes. So Everest was the name of the trial, which I thought would be rather to mention here in Nepal. It was a negative trial. So if you look at the ACC guidelines, it is not mentioned at all. And in the European guidelines, there's one mention in the text, which says can be considered to increase serum sodium and diuresis in patients with persistent hyponatremia. So the only time I use tolvaptan in my patients, if their sodium is 120, between 120 and 125, and they haven't responded to diuretics, and I add tolvaptan. But I will admit, most of the time, but sometimes it works, sometimes it doesn't. It doesn't always work. Hyponatremia is basically a marker of severe heart failure. So in this algorithm, I want to highlight the next step. So we give a patient of a diuretic, and I said we need to assess how they're doing. So typically, we have assessed patients by measuring urine output after 6 hours, which is mentioned. But the other thing this guideline mentions is to measure urinary spot sodium. So what is the sodium content of the urine? And for many of you, this may be a novel concept, so I want to highlight how this has come about. So a lot of the data about this is mainly from the Europeans. So ENACT-HF was an open label trial which enrolled 400 patients from 18 countries. And so they gave a diuretic. Again, this was a high dose loop diuretic. They gave double the patient's home dose up to a maximum of a dose of 200 milligrams of furosemide. And they measured urinary sodium, and their goal urinary sodium was greater than 50 millimoles per liter. And if the goal was, and a urine output of greater than 100 cc's per hour. And if the goal was not met, they doubled the next dose of the diuretic, again, to a maximum of 200 milligrams. So what they looked at was, so they collected all the urine. So the primary endpoint was natriuresis after 1 day, and they did find in the protocol of using urinary sodium, these patients did have natriuresis, but then also they had more cumulative natriuresis at 2 days and also more cumulative diuresis. Again, this trial was not designed to look at hard clinical endpoints, but showed that these patients diurese more. Another novel way to diurese patients that was studied was in this trial called ADVOR, which looked at acetazolamide in decompensated heart failure patients. So acetazolamide reduces proximal tubular sodium resorption. So this trial looked at acetazolamide versus placebo added to IV loop diuretics. And once again, getting the theme here, IV loop diuretics had to be 2 times the oral dose. So there was no low doses used in this trial. The acetazolamide dose was 500 milligrams daily. Interestingly now, when we look back at the study, they excluded SGLT2 inhibitors. And why is that? Because this trial was published in 2020, 2021, and during that time, SGLT2 inhibitors were first being used. So some of the patients in the trial would have been on them, most of them would not have been, so they wanted to exclude that as a confounding factor, given that in the grand scheme, this was not a huge trial. So they didn't want that factor. Again, now we would consider that a limitation because SGLT2 inhibitors are now standard of care in patients with both HFrEF and HFpEF. And the primary endpoint was successful decongestion, which was defined as the absence of signs of volume overload within 3 days of randomization. Again, no hard long-term clinical endpoint, but they showed that successful decongestion was far more likely to patients randomized to acetazolamide compared to placebo, 80% versus 60% at 2 days. So again, this is a large, in terms of decompensated heart failure, this is a large trial. They were able to show successful decongestion, higher urine output with no large safety concerns. But again, this is one trial. If you look at the cons, SGLT2 inhibitors were excluded. We diurese patients better, but what does it mean in terms of heart failure readmissions, urine, creatinine 2 months, 3 months following discharge? And there was slightly more worsening renal function based on slightly increased creatinine. But again, it was felt to be safe. In the United States, I will admit, acetazolamide is not really taken off. I've not utilized it much in my practice, and when I've talked to other doctors, again, I brought up our pharmacists, they've asked pharmacists at other hospitals, they have not seen a widespread use. But I want to bring it up because unfortunately the way we diurese patients today is very similar to how I did it in my training about 20 years ago. So this is a algorithm. The point is not to look at all the points, But it's an upcoming trial. This was just published in the Journal of Cardiac Failure. This will mainly be run in Europe, but it's going to be a trial of utilizing urinary sodium, utilizing acetazolamide. So maybe when I give this, if somebody gives this talk 5 or 10 years from now, we will be discussing this as the new paradigm, that it becomes standard of care. I will say, obviously, the limitation of using urinary sodium is it does require more intensive care, right? You have to check up on the patient. The nurse has to draw it. If the patient doesn't have a catheter, the patient has to urinate, measure, save the urine, and you have to check what, if you send it off to the lab and then check on it. So it is more labor intensive. So is this, I can do this at my hospital where I round with 5 or 6 other people. I round on 20 patients. Other doctors may round on 40 or 50 patients in the hospital, and they're off doing procedures, reading echoes, and so whether they have whether this can be utilized in many hospitals remains to be seen. One of the questions I also get asked in meetings sometimes is, does the choice of an oral diuretic matter? So you give patient intravenous diuretics in the hospital, now you send them home. Should you put them on furosemide or another agent? So this was attempted to be studied in a trial called Transform-HF, where they randomized patients to torsemide versus furosemide upon discharge, looking at a very hard endpoint, all-cause mortality. And unfortunately, out to 30 months, there was no difference. I say unfortunately because we all think that maybe furosemide has some limitations. Maybe we could show a better outcome with another diuretic, but that was not seen with this trial. So the next question I want to ask is, a 67-year-old female is admitted to the hospital with severe decompensation of chronic systolic heart failure. Her EF is 25%. Upon admission, she is on furosemide, carvedilol, sacubitril, valsartan, spironolactone, and dapagliflozin. She's severely volume overloaded. It requires continuous infusion for a diuresis. Due to worsening renal function, she was started on dobutamine during hospitalization. She then responded. Because she was started on dobutamine and borderline blood pressure, all of her GDMT was stopped. Her renal function worsened, but has now returned to baseline with creatinine of 1.4. Dobutamine was weaned off 24 hours ago. She remains on IV furosemide at 80 IV BID, as she appears still some volume overload. Pulse is 92, blood pressure is 104/70. Potassium is 4.0. What do you do now? A, start low-dose sacubitril valsartan. B, start spironolactone, 12.5 once a day. Start, we could show the QR codes up there. C, start low-dose metoprolol XL, or D, do not start GDMT until the patient has been transitioned to oral diuretics. So I'll give you a few moments. So this patient has known heart failure, was on every medicine, came in with decompensated heart failure. Everything was stopped because she was quite sick and was on dobutamine, and then the dobutamine was stopped, and you're looking to potentially restart one of her home medications. Okay, maybe we finish in a few seconds. Okay, so this is good. There's a lot of different answers, because I would say there is no one right answer. In my opinion, there's one that I would not choose. But before we get to that, we'll go through the next few slides. So it looks like the majority now said spironolactone, if you want to go back to my slides. So when new medications are started in studied in clinical trials in heart failure, we start with outpatients. So once they're approved and show benefit, there is this maybe hesitancy to use these medications in the hospital. So sacubitril valsartan was studied in Paradigm-HF, and there was an outpatient trial. But once we see benefit in outpatient, then we wonder, are these medications safe to be started as an inpatient? So Pioneer-HF was designed to study this question, which randomized stable patients that were not in hypotensive, not in shock, not in AKI, responding to diuretics, who were then randomized to sacubitril valsartan versus enalapril. And not only did they find that it was safe to put patients on sacubitril valsartan, but if you followed these patients up to 2 months, there was a reduced risk of CV death and heart failure hospitalization in patients on sacubitril valsartan, suggesting that not only is this medicine safe, it is potentially advantageous. So we should be using these medications in the hospital. Now, it is not uncommon, like the case I showed, that heart failure medications are often withdrawn while patients are in the hospital, Or when you take care of them in the hospital, you'll see that they've never been started on a drug, and you wonder why. So if we look at some retrospective analysis of some studies, there was an analysis of the Optimize HF registry, which enrolled over close to 6,000 patients in 90 centers across the United States. When they looked at these patients when they were in the hospital, if patients were withdrawn from a beta blocker and never restarted, they did the worst out to 90 days following discharge. And the second group were those that were never treated with the beta blocker. Now, this is an analysis. There could have been good reasons these patients were not on a beta blocker, but it really highlights we have to have a good reason not to put a patient on a beta blocker. It is not enough to say, well, I don't want to start one, or I think the patient may be too sick. We have to really look at these patients objectively and say we really should try to get these patients on GDMT during their hospitalization or to continue it unless there is a contraindication. The same thing was seen with ACE and ARBs. If these patients were withdrawn or never started during the hospitalization, these patients did worse than those that were started on these agents and also those that were continued. Again, there could be a bias. These patients are sicker that were continued, but it really just highlights that we really need to have good reasons not to start medications. Like the question that was brought up earlier, blood pressure of 80/40 upon discharge would be a reason not to start somebody on an ACE or ARB, but having a blood pressure of 110 or 70 would not be. We should start a medicine and even keep the patient maybe another day in the hospital to show that they're tolerating it. The other thing we have to realize is if you start GDMT in the hospital, they're much more likely to be on it 12 months later. So again, there's a lot of reasons for this. If you send a patient home not on a medicine, maybe they don't see you back in clinic. They come from far away, they see their primary care physician, and the primary care physician's maybe nervous about starting a medicine. Blood pressure is 110/60, or they may think, oh, they didn't put the patient on ARNI in the hospital, maybe I shouldn't be doing it as an outpatient. So there is a lot of benefit to having these patients on GDMT during heart failure hospitalization. So the other thing is that inpatient admission is an opportunity to optimize patients. So as I said earlier, SGLT2 inhibitors are now standard of care for HFpEF patients. That's a new recommendation from last year. So if a patient has had HFpEF for a number of years, maybe they never were started on an SGLT2 inhibitor, and now they come into the hospital, it's a perfect time to start an agent. MRAs and SGLT2 inhibitors have diuretic effects, and they may augment, potentiate diuresis. I often use spironolactone in the hospital to correct hypokalemia because of the IV diuretics. And GDMT should be continued during hospitalization in the absence of hypotension, shock, acute kidney injury. When I was training 20 years ago, we routinely stopped beta blockers if patients came into the hospital. We would never do that now. We sometimes do because they're quite sick or in shock, but if they're normotensive and responding to diuretics, we don't have to stop any of their GDMT agents. And if you do stop it, restart it as soon as you can. So I do think that if you look at this patient and they seem to be frail, you may not want to start GDMT that day. You may want to start the next day. But as a rule, I don't think D is correct. I don't think you have to transition a patient to oral diuretics to start GDMT. If they're still volume overloaded, still getting IV diuretics, but normotensive, you can definitely start GDMT. And I would also start spironolactone, but there's nothing wrong with A or C. I would usually probably wait 48 hours after weaning off dobutamine, particularly in an elderly patient. But you may say, nope, I can do it. And again, when the patient's in front of you, you may make that clinical decision. So there is really no wrong answer between A, B, or C, but I would probably start spironolactone. The next thing I want to talk about is cardiogenic shock. So Dr. Mukherjee earlier today mentioned cardiogenic shock in the standpoint of an acute MI. So these patients, they are walking at home, they get chest pain, and within 4 to 6 hours, they're in shock. So that is very different, we think, than heart failure cardiogenic shock. So one of my heart failure patients may have an EF of 20% and be doing well for 5, 10 years and then slowly start to get worse and then get admitted to the hospital and found to be in shock. And we think that is a different patient population. I've had patients that I've seen in clinic that I think are low cardiac output. I bring them to the cath lab as an outpatient for a right heart catheterization or a PA catheter, and their mixed venous is 25%. I don't think you would see a mixed venous of 25% in an acute MI patient because they probably would already have succumbed to their MI because that's a massive MI, or they'll already be on life support or an ECMO. So, but heart failure patients can tolerate low cardiac output insidiously until they're no longer able to compensate. So as a result of this, there's a classification system that has been developed by SCAI in the international organization to look at cardiogenic shock more objectively. So how can we grade cardiogenic shock? So to say somebody's in shock, they could be on one inotrope or they could be in extremis getting CPR. So there's these 5 stages. Stage A, just like when we talk about stages of heart failure, at risk for shock. So you may not think they're at shock category yet, but they're at beginning, at risk for shock. B is beginning shock, C is classic shock, D is deteriorating, and E is extremis. And there are guidelines for how to diagnose this. I don't expect you to know all this, but just to know it's based on several factors. What is the systemic blood pressure? What is the lactate? What is the creatinine, liver function test, BNP, and then finally, what are the invasive hemodynamics? So it's not just good to know the blood pressure, because you have to know, just because somebody has what you think is a good blood pressure, 100/70, doesn't mean that they're perfusing. You can have a patient with a blood pressure of 100/70 and have an elevated lactate, elevated creatinine, and when you feel them, touch them, they're cool to the touch. So if I get a phone call from the States right now and a doctor calls me, he's like, your heart failure patient's in the hospital, their blood pressure is 90/60, I may look them up and say, well, it was 90/60 when I saw them in the office, so that actually by itself doesn't tell me anything. I would ask, did you check a lactate? Did you check a creatinine? And I think that's one thing that has changed in our field. We routinely check lactates now in patients that come into the hospital with decompensated heart failure, because we always get surprised that somebody has an elevated lactate despite the fact that they have a MAP over 70, and we just know we have to watch that patient closely because we would argue they're in the beginning or stage C cardiogenic shock. And so in the United States, there's been this impetus now that we should be getting more hemodynamics, placing a pulmonary artery catheter. So this, we don't do it in everybody with decompensated heart failure, but anybody we think is in the early stages of shock, we should place a PA catheter to see what are their hemodynamics, and then even to put a stitch in so we can leave the catheter in and then follow them over time. So we can see if they're decompensating, we can see what type of shock they have. Do they have right-sided shock, left-sided shock, or both? And then we can diurese them to goals. So, you know, if you admit a patient and they have a wedge pressure of 20 millimeters of mercury, and you diurese them, and tomorrow it's 12, and your trainee says, I want to keep giving diuretics, you would say, why? Their filling pressures are normal. We have to, you know, because you don't want them to develop hypotension. You also can use hemodynamics to decide when to put a patient on inotropic support, dobutamine, or milrinone, and then to see if you need to escalate their dose. Unfortunately, there's not a lot of, or not any real prospective data showing the benefit of a PA catheter in cardiogenic shock, but in the US, we are starting to look at registries and show the benefit of PA catheters in retrospective analysis, and there does appear to be a signal that if patients have a PA catheter in place and have the data, you know, does you no good to have a PA catheter if you don't record the data, PA pressure, cardiac output, wedge pressure, right atrial pressure. If you do if you do measure and assess hemodynamics, those patients may do better. And so now we have algorithms to look at how to manage patients with cardiogenic shock, you know, what inotropes to use, what pressor to use if they're hypotensive. So again, not all cardiogenic shock patients need a pressor because they may be normotensive, but you can still be in shock, basically be in low output failure. So now the paradigm shift has been if patients are hypotensive in cardiogenic shock, the pressor of choice is felt to be norepinephrine as opposed to dopamine, mainly, and to add on other pressors if patients don't respond to norepinephrine, and then adding an inotrope if they're low cardiac output. So again, we have to have a high index of suspicion when patients have low cardiac output. So again, we routinely in our patients will place a PA catheter, and not only can they aid in the diagnosis of shock, but also improve outcomes and assess when patients are not doing well. Now again, there are adverse events associated with milrinone and dobutamine like arrhythmias, so unless a patient is crashing and we don't have time, I usually don't start an inotrope unless we get hemodynamics first to show that the patient needs inotropic support. And so the final thing I want to discuss in a few minutes is the natural history of heart failure. Again, our goal is to keep people doing well for as long as possible, but unfortunately, that may not be possible for all patients, and they may reach the end stages of heart failure, which we sometimes refer to as advanced heart failure. So what is advanced heart failure? Multiple different societies have multiple definitions and clinical criteria, but I want to focus where they intersect. These are patients with severe symptoms, recurrent hospitalizations despite optimal medical therapy. So are there other options for these patients? The hope is that we can hopefully find new medications, new procedures to ameliorate this. So I know that in transplantation has now become, actually I'll skip to the next slide, that should have been hidden. So I know that there is a transplant institute in Nepal where you've started doing renal transplant or liver transplant. India has started, I don't know the exact year when they started heart transplantation. So obviously, even in the US, transplant is not for everybody. Many patients lack the resources or have other comorbidities. But you know, the hope, unfortunately for some patients, transplant is necessary, but our hope with every patient is that we can develop medications, procedures to prevent that. And finally, in India, recently, LVADs have finally come around. LVADs are mechanical pumps to assist the function of the left ventricle called LVADs. We've been using them in the United States for over 10 years. Now we use the HeartMate 3 device, and that just recently got implanted in India. So there are other devices, which in the interest of time, I'm not going to talk about. Again, they've been shown in the United States to improve symptoms, but not all of them have been shown to improve survival. These are procedures like pulmonary artery sensors or CardioMEMS, carotid sinus modulation, also baroreflex activation therapy. The trade name is Barostim, and then cardiac contractility modulation. But again, we're still out there trying to find better outcomes for our patients, because even now today, we can never say heart failure patients are truly cured, truly stable, that we are looking for better and better devices and better medications so that we can cure this, this illness instead of just extending life expectancy. So thank you for your attention.
Thank you, Dr. Naveen. That was a very practical session. I think we see these cases day to day in our day-to-day clinical practice. I think there will be questions. Any questions from the audience? There must be.
Would you like to differentiate among furosemide and torsemide? What is your protocol?
Furosemide and what?
Torsemide.
Torsemide.
Yeah.
Yeah. So furosemide and torsemide are both loop diuretics. There's some idea that torsemide has better oral bioavailability, better absorbed. So I actually forgot to mention this in my talk, so I apologize. So in the trial, they showed no difference. But in a particular patient, a patient may respond better to one versus the other. So there are many patients that do respond better to torsemide than furosemide, because I've started patients on torsemide as opposed to furosemide, and they sometimes diurese better. So it can be individual and in a single patient, but do remember those medications act on the same part of the kidney, so a patient should never be on both. Sometimes patients get confused and they're taking both at the same time, which doesn't make any sense, but that's usually because they have an old bottle and they did not take another. So there's no data that say that one agent is better than the other. I personally have started to use more torsemide than furosemide. But even once, a month ago, I got denied by a patient's insurance company. Makes no sense. These medicines have been around forever, but insurance companies in the United States often don't make any sense.
Thank you, sir. I have seen in one of your slides, the use of ARNI in preserved ejection fraction. So heart failure with preserved ejection fraction, use of ARNI. In one of the slides, what is the indication of ARNI in preserved?
ARNI in preserved ejection fraction?
Preserved, yes.
Yeah, so unfortunately, I didn't have time with both my lecturers to talk about HFpEF, because that would take too long. So ARNI does have a role in HFpEF. The clinical trial was which was called Paragon HF for ARNI and HFpEF, did not reach statistical significance. The p-value was 0.06. But if you look at the official guidelines, SGLT2 inhibitors have a class 1 recommendation. ARNI is a class, I believe, 2A. So typically we use ARNI in HFpEF patients that are hypertensive. So because they are good at lowering blood pressure, so if a HFpEF patient has high blood pressure, I do believe they should be on SGLT2 inhibitor and ARNI. And it's even a stronger recommendation if they're diabetic, because all diabetic patients really should be on an ACE or ARB or ARNI. So I do think, so in the United States, we do often use ARNI in conjunction with SGLT2 inhibitors for HFpEF.
So what about the SGL2 inhibitors?
What?
SGL2 inhibitors like dapagliflozin in use of preserved EF.
Yes. So every patient with HFpEF, proven HFpEF, meaning that they've had a heart failure event or they have an elevated BNP, their EF is normal. Actually, because they're approved for low EF, it doesn't matter what their EF is. All patients should be on an SGLT2 inhibitor unless they have a contraindication. There's really no strict contraindication. The biggest one would be they're not well studied in type 1 diabetics, but because they can cause DKA. But some I've worked with endocrinologists who said this patient never had DKA. They are compliant. They can be on an SGLT2 inhibitor. So there's very few patients that cannot be on an SGLT2 inhibitor.
Thank you.
Sir, any question? Maybe.
Sorry to come back again. These patients, your first case, the case with heart failure with preserved ejection fraction, you said the patient deteriorated because of dietary non-compliance. What is the dietary non-compliance we are talking about in a patient with heart failure with preserved ejection fraction?
So, so a patient with heart failure with preserved ejection fraction, usually almost all those patients have other comorbidities, usually hypertension or diabetes and obesity. So even though those patients have a normal EF, if you did a hemodynamic study, like put a PA catheter, you'd see that these patients often have an elevated wedge pressure. Or if they have a normal wedge pressure and you provoke them either with a saline bolus or exercise, which I know is not available everywhere, you would see an exaggerated increase in their LV EDP or their wedge pressure. So even though the EF is normal, these patients can be prone to volume overload. So if they take too much salt, too much fluid, they may develop decompensated heart failure. Now, I will just say as a side point, fluid restriction in any form of heart failure has never been proven to improve outcomes. It's hard to study because in any clinical trial, you're going to randomize motivated patients. I certainly have seen patients that drink way too much salt. They carry a water bottle to their clinic office. I work in a place where we have cold weather. There's no reason for somebody to carry a water bottle the whole day because they're not sweating. But some patients will drink 3 to 4 liters of urine, or they'll drink ice all day. And so we try to counsel them. But fluid restriction, I never do less than 2 liters. So some doctors do 1 liter, 1.5 liters. I don't think that's useful. I think patients will just get discouraged, and then they may not see you because they just feel so unhappy. So, but as a rule, fluid restriction has never really been shown in a clinical trial to improve outcomes.
Thank you, sir, for a nice presentation. I just one query, because even after the increasing with the IV diuretics with the 2 to 3 doses that you have mentioned, sometimes we get a patient with a diuretic resistance, and then we try in our country, like when you get a diuretic, even at the IV, we try to ask the distal convoluted tubule sodium potassium inhibitors like the metazolones, like this. So what will be your tackling process for the patient who are, even after those patients who are even increasing the dose of diuretics, those go into diuretic resistance?
Going into what?
Diuretic resistance patient.
Diuretic resistant.
Diuretic resistance, oh. So there's really no one strategy to prevent diuretic. I mean, typically what you're referring to is diuretic resistance. The creatinine starts to go up. So again, unfortunately, no one, we used to think maybe a drip would be better. I don't have a simple answer because nobody has an easy answer to that. The key is to keep, to diurese patients as much as possible. I think the one mistake that is made is that doctors sometimes see the creatinine go slightly up and stop diuretics. So again, if a patient's volume overloaded, they need diuretics. I'll make a last point. I once spoke to a physician who said, he asked me, he's like, when I diurese patients, the kidney doctor shows up and stops all diuretics. And he's like, how do you prevent that? And I said, well, I prevent that because I don't get the kidney doctor involved. So at his hospital, the primary care doctor consults all these people, so he doesn't have that choice. But we sometimes do get kidney doctors involved. I think there is a role. We are trying to develop more collaboration. But if a patient is still volume overloaded and their creatinine goes from 1.3 to 1.5, 1.6, you keep the diuretics. Now, I'm sure you're referring to cases where it's 1.5, 2.2. These are very difficult cases. Sometimes we have to think about it. We do have options in the U.S. for some of those patients, inotropic support for the low EF patients. But if you have a patient with HFpEF, overweight, a diabetic, hypertension, elderly, they're very difficult to manage patients. So I'm trying to give you confidence to know that you're doing everything you can. Sometimes these patients just don't do well with the best that we have to offer.
Maybe Sampurna sir has one question. No?
My question is really of an economic issue. So what happens in America is very different from what happens in Asia and maybe in India. Maybe this discussion has been going on. At the end of the day, you need a great heart. You can put diuretics, you can put machines and this and that, but at the end of the day, it's transplantation. But you need a brain dead, and that's very difficult at the same time. Okay, you might have LVADs as a destination therapy, that's one issue. But the thing is, how can you make it economical and at the same time have a great heart failure and heart transplant program? Some of the things that has been discussed, like can we have more cheaper ECMOs? That's where the patents have run out in US, maybe it's manufactured in India or China. And because this just the disposables of the ECMO is about 2 lakh rupees, which is extremely difficult. Have you had any thoughts with the Indian counterparts about all these ideas? And if I can push this to the extreme limit, so we're now getting genetically edited pigs having kidney transplants. Has this imagination been brought up in US that maybe it can have genetically edited heart transplants? I'm just pushing it. I mean, we can have genetically edited pigs giving hearts at the same time. Has this imagination been pushed? That's the extreme end I'm talking about.
Yeah, so I mean, just so you're aware, a transplant of the heart is, in terms of management afterwards, is very similar to kidney transplant. Obviously, we have to do biopsies of the heart, but the medications are the same. The immunosuppressions are the same. But obviously, even in the U.S., transplant is not for, we unfortunately turn people down in the U.S. because of lack of insurance, or they don't have good enough insurance, or they don't have an adequate transportation. There are some states in the U.S. that don't have transplant programs because you need a big population base. So if you're only doing 5 transplants a year, you don't get good enough, and you can't employ a cardiologist, because not all cardiologists in the U.S. know how to take care of a transplant patient. You have to have specialists like myself. Because if Dr. Mukherjee had a transplant patient and I was working with him, he would call me and say, how do you manage this patient? Just like I don't know, I know how to manage a patient after a stent. I can't put a stent in, but I can manage a patient after a stent. Dr. Mukherjee can tell me, hey, this patient needs a transplant, but once they get a transplant, he'll say, I take care of them. So there's a lot, if you have a big country, you have a lot of specialization that can occur. I will just tell you, there's nothing that we do in the US that's been proven to work in heart failure that you aren't using here. There's a lot of tools that we have, ultrafiltration, barostim, cardiomems. They're very niche things. The companies kind of not force, but they encourage them a lot. But if you look at the data, they're not saving a lot of lives. They improve some outcomes, but at the end of the day, the best heart failure therapy is GDMT and diuretics. So if our goal is to prevent transplant, so it's never sometimes good news that we have to do a transplant. Obviously, in a young person, sometimes they were going to die without it, so it's heartwarming that they got a transplant. But yes, we realize that there will never be enough donors to save patients, so they are looking at genotransplantation. So in the US, they've done some pig transplant, but so far it hasn't worked out. The outcome, they've only done a couple. They've done some in other organs that's been more promising, but the heart transplant is still the heart pump, which is very expensive and requires a lot of care, and heart transplant. Thank you.
Well, that was a very interactive session. I think very nice one, eye-opener for us that we are doing good, even though we don't have many facilities over here. Now we are in the last presentation, and I would like to invite Dr. Latha Palaniappan again to deliver our talk on emerging therapies in lipid management, what's new and what's coming. This session will explore recent advances in lipid-lowering therapies, highlighting novel options for managing dyslipidemia. She will review emerging treatments with a focus on practical consideration for integrating these therapies into clinical practice. Dr. Latha Palaniappan.
Thank you. Thank you again, everyone. It's the final session. Everybody get up again. Let's take another stretch break. Not sedentary today, no sedentary behavior. And let's give Dr. Deb Mukherjee a round of applause for chairing this session. He has kept all of us in line for all of the sessions, and we're so delighted to be at the last session today. Okay, so now we're going to talk about emerging therapies, what's new and what's coming in lipid management. We'll talk about current treatment options and what is coming up in the future. So I was surprised to find this data about Nepal. And so on the left-hand side, you have cardiovascular risk factors ranging from diet high in sodium, diet low in seafood, high fasting plasma glucose, diet low in nuts and seeds, high body mass index, diet low in fruits, diet next one after that is high LDL. And so that's what my two talks are focused on. I was surprised to find that smoking rates in Nepal are about 20%, which is about double what it is in the United States now. And then on the graph on the left, you can see 98% of adults in Nepal have one or more cardiovascular risk factors, as you see in the disability adjusted life year graph. And this is in comparison to about 90% in the US. So lots of room for improvement in all of these risk factors in Nepal. And then I'll point out the bars have, this is a stacked bar graph with ischemic heart disease in blue and stroke in orange. And that is most of the cardiovascular disease that is represented. And stroke is more influenced by blood pressure than cholesterol, and we see this in other areas of the world as well. So dyslipidemia is a major risk factor for cardiovascular disease, and the WHO estimates that 40% of adults have total cholesterol levels greater than 190 or more. It was a little bit less, as we saw in the province maps of Nepal. So high Lp(a) is a biomarker for atherosclerotic cardiovascular disease. May I have a show of hands how many of you are checking Lp(a) in your patients? Okay, a few. I encourage more of you to do this, because 1 in 4 South Asians have high elevated Lp(a), and it is not yet a standard guideline. In the ACC, AHA, they recommend testing. They recommend testing at least once after the age of 18 for Lp(a). And it is a genetically determined risk marker, so you don't need to check it more than one time. So 1 in 4 South Asians have elevated Lp(a). I don't have numbers specifically for Nepal, but it is one of the highest rates in the world. I'm noticing a lot of conversation in the room, which makes it difficult to speak. So if you would like to have a conversation, if you don't mind stepping outside, that would be helpful for me. Thank you. So Lp(a) testing is recommended particularly in families with family history of premature coronary disease, which is defined as less than 55 years in men and less than 65 years in women. Also in patients after acute coronary syndrome, because it's helpful to know if your patient has high Lp(a), because their children have a 50% chance of inheriting this high Lp(a). And particularly also if you have people with strokes of uncertain etiology, Lp(a) is helpful. And by expert consensus, the Lipid Association of India has decided that an Lp(a) of greater than 20 indicates risk in Indians, and an Lp(a) of over 50 indicates particularly high risk. And in other societies, the Lp(a) cut point of 50 is what is generally recommended as very high risk. So there's currently no specific treatment for elevated Lp(a). So statins increase Lp(a) by a little bit. PCSK9 inhibitors have shown some benefit in lowering Lp(a). And on the horizon is a drug, an antisense oligonucleotide called pelacarsen, which targets the mRNA that transcribes the Lp(a) gene. And so this will lower Lp(a) by 80%, and is currently in phase 3 trials now. And so on the figure on the left, you see basically the distribution of Lp(a). And pelacarsen will be able to take people with Lp(a) levels of 150 or higher and bring them down to the normal range. Other drugs that are useful for Lp(a) are niacin. Unfortunately, there have been no cardiovascular outcomes trials of niacin that have shown that it has been helpful for lowering Lp(a) and then lowering cardiovascular events. So we're going to talk about statin intolerance again in this talk. I'll talk a little bit more about SLC01B1, slow metabolizers, which is much more common among Asians. This encodes the OP1B1 receptor in the hepatocyte, and this results in more statin-associated musculoskeletal symptoms. So as I mentioned in the question and answer session, statins in combination with other statins or adjunctive therapies can increase effectiveness in terms of lipid lowering. So on the negative y-axis, you have LDL reduction, and you can see that adding another drug like ezetimibe, and that's a great choice, and it's nice that you have combination therapies, of adding ezetimibe, it lowers LDL by an additional 22.5%, more than just doubling your statin dose from atorvastatin 40 to 80. It's helpful to add ezetimibe or add bempedoic acid or add a monoclonal antibody or add inclisiran. So in terms of new and emerging therapies, I want to talk particularly about bempedoic acid. A lot of people in India were using bempedoic acid, and I think it will probably be used a little bit more in Nepal in the coming years. So bempedoic acid works in the same HMG-CoA reductase pathway. It's the step before statins. And the good thing about bempedoic acid is that it's metabolized mainly in the liver and not so much in the muscle. So there's less muscle side effects with bempedoic acid. Ezetimibe works by decreasing cholesterol absorption in the kidney by inhibiting NPC1L1. And the PCSK9 inhibitors work by stopping PCSK9. So PCSK9 is what breaks down the LDL receptors. So if we interrupt PCSK9, either through monoclonal antibodies or by small interrupting RNAs, what happens is then we have more LDL receptors to clear LDL from the blood. So bempedoic acid is a prodrug that's metabolized in the liver, and in contrast to statins, it actually decreases diabetes and insulin resistance. Statins increase diabetes by just a little bit, and it also has effects and is being studied for reducing non-alcoholic steatohepatitis and metabolic-associated steatotic liver disease. The cost is actually much lower than what is on this slide, very affordable, about 24 INR, Indian rupees per dose. In the US, it's still quite expensive. So the clinical trials for bempedoic acid on the left are bempedoic acid as an add-on to statins, And even adding on to statins, you get an additional 20% LDL lowering, even though it's in the same pathway, because you're blocking more of that HMG-CoA reductase. And on the right, you have bempedoic acid in statin-intolerant patients. So 1 out of 10 of your patients who take statins will be truly intolerant of the statins, and so you can use bempedoic acid in them, and you get 20 to 30% LDL lowering. And bempedoic acid is the one new therapy, emerging therapy, that I will talk about today that has cardiovascular benefit in terms of MACE. And so this was a trial done and published in 2023 in the New England Journal of Medicine, about 14,000 people over 40 months. And this is, bempedoic acid is oral, and it's the first oral non-statin therapy to reduce CV events as a monotherapy. Everything else has been studied in addition to statins, on top of statins. But this is bempedoic acid alone. It has a favorable glycemic profile and is muscle sparing in terms of its mechanism, and it's great for statin-intolerant patients. So in terms of LDL reduction, it was 21% LDL reduction from baseline, and statins, the high-intensity statins, you get about a 50% reduction of LDL. So the primary outcome was 4-point MACE, CV death, MI, stroke, coronary revascularization. The absolute risk reduction is 1.6%, and this calculates, so the number needed to treat is 1 over the absolute risk reduction. So the number needed to treat is 63 people over 3.4 years, and this is in comparison to statins, which is about 50. So bempedoic acid, it takes a few more people to treat, but you get nice improvement in survival. And it may have some benefits over statins, and we'll see in the years to come if bempedoic acid becomes more commonly used than statins. So PCSK9, the small interrupting RNA, the mechanism is then the PCSK9 is not transcribed as a protein. PCSK9 breaks down the LDL receptor. When you stop that, you have more LDL receptors, and there's more LDL being cleared from the blood. Anyone using inclisiran in the audience now? One person, wonderful. We had just 3 or 4 people in India, so I think in the coming years we'll see this a little bit more. So we have some trials showing the inclisiran versus placebo. On the top, we have Orion 10. On the bottom, we have Orion 11. On the left, we have percent change in LDL. On the right, you have absolute change. And I'll just point out on the right-hand side that we're starting with an LDL of 100. So these are people already with low LDLs, and you're still getting nice 50% reduction in LDL with this drug. In terms of the monoclonal antibodies, Repatha, so this works by binding to PCSK9 mRNA, causing PCSK9 to be degraded. PCSK9 then is not there to break down the LDL receptors. We have more LDL receptors, and then more LDL is being cleared from the blood. Anyone using evolocumab in the audience? Okay, not yet. This is very hard to get approved in the US now as well. And new at ACC in 2025, we have, how many people were in New Orleans for ACC this year? Okay, I think there's one person in the audience, and this was presented there. We now have an oral option for PCSK9 inhibitors, and you can see on the left we have a nice dose response with LDL lowering. And on the right, you know, I also want to point out that we still don't have cardiovascular outcomes on this yet, but nice dose response, and we should be seeing this coming out in the next few years as well. So brief mention about fibrates. This was brought up in the question and answer session of the last talk. As we know, fibrates are used to treat high triglyceride. The first fibrate, clofibrate, was approved in 1967. The newer fibrate, pemafibrate, was not approved in the US due to the fact that the international clinical trial was not shown to be useful in terms of cardiovascular outcomes. However, it is approved in Japan, so I do think that there are some differences among Asian race ethnicities. Europeans make up approximately 9% of the world's population and 90% of the genetic studies. In contrast, South Asians make up 25% of the world's population and only 1% of genetic studies. So I think there's still opportunity to do these studies in South Asia, and we should, because the pathophysiology that you're seeing is different from what is being published in terms of dyslipidemia. So fibrates are typically prescribed in tandem with statins, and I think that's a good choice because you have all of the cardiovascular outcomes which are proven with statins, and you're still getting the triglyceride lowering that patients and you want, because it's always nice to see the labs within normal limits. So this was the pemafibrate trial called Prominent that unfortunately did not show an improvement in cardiovascular outcomes among patients with diabetes and hypertriglyceridemia. So you can see for non-fatal MI, ischemic stroke, coronary revascularization, or death, that MACE outcome, it didn't make it. In terms of the p-value at 0.67, you see that hazard ratio crosses 1. So this was a negative trial, and pemafibrate was not helpful and also harmful in terms of a significant p-value, 0.004 for increase in renal events. So this is why pemafibrate is not being used in the United States. It is not FDA approved. Omega-3 fatty acids are also a great choice to lower triglycerides. We typically use this in very high triglyceride situations, triglycerides in the 2,000, 3,000 range, to really prevent pancreatitis. And this was really shown to be helpful in REDUCE-IT most recently. So for patients on statins with mixed dyslipidemia at high risk for coronary heart disease events with triglycerides greater than 135 to less than 500 and LDL between 40 and 100. And REDUCE-IT did show that omega-3s were helpful for reducing those, reducing risk in those with high risk for CHD events. And then in terms of icosapent ethyl versus placebo, the number needed to treat is quite robust at 21. And you see the risk difference for the primary composite endpoint, which is made up of cardiovascular death, fatal or non-fatal MI, fatal or non-fatal stroke, and coronary revascularization, as well as hospitalization for unstable angina. There was improvement in all of these outcomes, slightly higher hospitalization for atrial fibrillation or atrial flutter in those taking icosapent ethyl and REDUCE-IT. Okay, so let's go to our case studies. Our first case is a 48-year-old male South Asian office worker with hypertension diagnosed 2 years ago, has history of ASCVD already with an MI with stent in the LAD at the age of 46. Patient has a sedentary job, low physical activity, vegetarian diet, which is high in refined carbs and ghee. Fortunately, a non-smoker, occasionally drinks alcohol. BMI is 28. Blood pressure 138 over 84. eGFR is normal at 90. Total cholesterol is 245. LDL is 168. HDL is 37. Triglycerides slightly high at 230, as you see in all of your patients that low HDL, high triglycerides. Hemoglobin A1C of 5.9. CRP of 3.2. After encouraging lifestyle modifications, dyslipidemia persists. What is the next step? A, start bempedoic acid 180. B, start Repatha evolocumab at 420. C, start atorvastatin at 40. And I'll remind us as we go to the answers that this person already has a history of ASCVD, so we really want greater than 50% LDL lowering in this patient, and picking the right intensity of statin is important. Great, so most of you are choosing the atorvastatin at 40. Given cost, perhaps in the future, bempedoic acid might be a good choice, and particularly if you're finding more statin intolerance in your patients, bempedoic acid would be a great choice. But now, according to the guidelines, atorvastatin 40 is the correct choice. And then just going over again the choosing the right statin. So for those with ASCVD, high-intensity statin is recommended, and those with very high 10-year atherosclerotic cardiovascular disease risk over 20%, and everyone with diabetes automatically should be on a moderate intensity statin. So your choices are, for those with diabetes, atorvastatin 10 to 20, or rosuvastatin 5 to 10, or simvastatin 20 to 40. Those are the sort of my top 3 choices there for the moderate intensity statins. So now our patient again complains of muscle aches, hair falling out. You check the CK and it's normal. So the patient has some signs of statin intolerance, and what's the next step here? A is consider adding inclisiran. B is proceed with statin rechallenge, stop atorvastatin and prescribe rosuvastatin. C is halt statin usage and start Repatha, evolocumab. So we can go to that question. I'll just point out that this patient's BMI is not that high, but South Asians definitely do have higher risk of atherosclerosis, even at lower BMI and LDL levels, which I have done some work in this area as well as many others. So very important to treat these patients well. So, okay, a lot of you are choosing evolocumab. That might be the right choice in the future, but currently the guidelines are to try another statin. So we would stop the atorvastatin and prescribe rosuvastatin according to current guidelines. And again, I think we're coming up upon a very exciting time in lipid-lowering therapies, and the guidelines might be rapidly evolving going forward. Okay, so let's talk a little bit about rosuvastatin. In the US, a lower dose of rosuvastatin is recommended for Asians. So 5 milligrams is recommended as the starting dose for Asians instead of 10 because of increased risk of statin-associated musculoskeletal symptoms. This has mainly been studied in Japanese and Korean populations, but there's a blanket black box statement for all Asians on the prescribing notes for rosuvastatin because of the higher prevalence of SLC01B1 slow metabolizers. I myself am an SLC01B1 slow metabolizer, and I'm excited as we do more genetic studies in Nepal and India if we find that that is more prevalent among Asians. So this again is our statin intolerance framework. Important to try 2 statins before you move on to one of these exciting new therapies, including ezetimibe, PCSK9 inhibitors, bempedoic acid, and inclisiran. So unfortunately, statins do work for 90% of the population, and as we have seen, fairly underutilized in Nepal at the moment. So I think lots of room for improvement both in the US and Nepal going forward. Okay, so this is the next step of our case. So the patient continues to have SAMs after trying the lowest dose of rosuvastatin. So after trying the second statin, what is the next step? So increase atorvastatin to 40, stop statin use and start Repatha, or C, stop statin use and consider red yeast rice alone. So great, evolocumab was a choice at the last step, but it's currently the right choice here because we've already tried 2 statins, and most of you have answered correctly that Repatha is the next step. There's a great study comparing all of the over-the-counter things that patients are using, including red yeast rice. It was called the SPORT trial. I have it in another set of slides. But important point for your patients is that none of those other sort of naturopathic remedies work as well as statins. So alternatives to statin monotherapy currently are ezetimibe, PCSK9s, bempedoic acid, and inclisiran. And we definitely want to make sure that those with any clinical ASCVD, as our patient had, or very high risk, or those with an LDL of greater than 190, as we see with familial hypercholesterolemia, that we're making sure that the LDL is lowered. And I just want to share how we approach this at Stanford, the reduction of residual risk with P5 medicine. And we really try to focus on prevention as well as better prediction, personalization, participation of the patient, and also psychocognitive aspects. We have a multidisciplinary team, including cardiologists, endocrinologists, general practitioners, internal medicine specialists, as well as geneticists that are helping us more with incorporating polygenic risk scores. And every one of our patients sees a dietitian as well as a lifestyle modification coach. We work with pharmacists as we saw in the previous talk as well, and lab specialists. So I think it really does take a whole team to empower the patient so they can really have agency in terms of reducing their risk of atherosclerotic cardiovascular disease. So with that, I will say thank you. And if we want, we can do questions now, or I know we're at time if we want to move on as well. I'll be available for questions after.
Any questions?
Rather, it's not a question exactly. I just want to know whether you've ever wondered that why only statins and statin-related drugs like PCSK9 inhibitor, they really show the cardiovascular benefit. But as there are so many cholesterol lowering drugs, including bempedoic acid, ezetimibe, and niacin, fibrates, bile sequestrants, and you see that none of them works, right? So I have a very different view regarding cholesterol and coronary heart disease. So what I believe is that the statin and the related drug PCSK9 inhibitor, both of them, actually what they do is they increase the LDL receptors. Increase the LDL, they upregulate the LDL receptors on the vascular endothelium. And you know, vascular endothelium is a very delicate, it has a very delicate structure. It's a phospholipid bilayer, and which is actually stabilized, the integrity is maintained by regular interpositioned cholesterol molecules. So what exactly statins and PCSK9 inhibitors are doing is they're increasing the LDL receptors on the membrane, so the cholesterol is being taken up by the vascular endothelium, and once it is inside the cytoplasm of the vascular endothelium, it is redistributed. And we know when it is redistributed, the 70 to 80% goes into the vascular endothelium. And that is how it stabilizes and maintains the integrity of the vascular endothelium. So actually, it does not depend upon the just decrease in cholesterol per se. It depends upon how it is decreased. So actually statins and PCSK9 are increasing cholesterol where it is needed. So that's my view. I don't know whether you've ever wondered about it.
Thank you for your comment. I do want to make one point that statins and PCSK9s work differently pathophysiologically. Statins decrease cholesterol production, and PCSK9s do increase the number of LDL receptors. I agree in both cases they are pleiotropic effects, so that means effects outside of just purely lowering cholesterol, which are helpful. And as we saw from the familial hypercholesterolemia slide, at every level of LDL, genetic risk confers more risk. So that means there's a lot that we're missing about risk reduction, and there's more to it than LDL. I agree with you. Maybe we should close up this session.
There is a feedback form that is provided in the back. You can fill it up and submit it to with the members of the Sun Pharma team, or you can scan the QR code and submit your feedback. Now we'll start the closing session, and to start with the closing session, we have the felicitation to speakers, and for felicitation, I would like to call upon our respected President of Cardiac Society of Nepal, Dr. Ratnamani Gajurel, on the dais. We'll start with Dr. Debabrata Mukherjee, who is also the program chair of this whole program. Dr. Debabrata. Thank you, Dr. Mukherjee. Next, we have Dr. Naveen Rajgopalan. Thank you, Dr. Naveen. Last but not the least, Dr. Ratha Palaniappan. I hope I pronounced correctly. Thank you, Dr. Latha. Now I'd like to request our President, Dr. Rathamani Gajuril, to deliver the vote of thanks and closing speech. Thank you.
Thank you, Dr. Dipankar. ढिलो भइसक्यो है respected seniors, international faculties from American College of Cardiology, dear doctors from different specialities, members of the Cardiac Society, Executive Committee of the Cardiac Society, my fellow colleagues, ladies and gentlemen. Namaste and good evening to all. As we bring the 11th Best of ACC scientific session at the conclusion here in Nepal, myself, the President of the Cardiac Society of Nepal, stand before you with immense pride and deep gratitude. On behalf of the Cardiac Society of Nepal, first and foremost, I extend my heartfelt thanks to the American College of Cardiology for continuing this invaluable partnership and allowing us to bring the latest advancement in cardiovascular science to our doorsteps. This collaboration has been very impactful in raising the academic standard of cardiology in our country. It has been a truly enriching experience this afternoon and the evening, filled with insightful discussion, cutting-edge sciences, and meaningful connections. These scientific sessions, 11th Best of ACC, is a testament to our shared commitment to advancing cardiovascular care, not just globally, but here at home in Nepal. For this, I once again express my sincere thanks to American College of Cardiology for bringing the Best of ACC to Nepal. I believe this collaboration is more than a conference. It is a bridge of knowledge and innovation that connects to our practitioner to the global frontier of cardiology and the other specialty also. To our esteemed speakers, international faculties from ACCs, your young clinicians from Nepal, dear resident, fellow, and all the attendees from the different specialty. I am seeing few of my teachers also. They are equally enthusiastic to participate in this program. Thank you for your enthusiastic participation. Thank you for your time, insight, and engagement. Your presence made this event both meaningful and impactful. Your presence gives life and energy to this event. And I believe your eagerness to learn and share will continue to shape the future of advanced cardiology in Nepal. I am confident your passion drives the future of cardiology in Nepal. To our pharma partner, Sun Pharma, thank you for your unrestricted educational grant and support and the partnership. Thank you, your generous and the sheer commitment to medical education and innovation. Your partnership, your dedication and planning has been crucial in making this event a success. You did a wonderful work behind the scene that have made this collaborative scientific session a memorable one. I don't have any hesitation to say your collaboration has helped us to deliver a high-quality scientific program and has definitely reinforced and proved the power of industry-academic synergy in cardiovascular healthcare advancement in Nepal. As we conclude the memorable event, let us carry forward the knowledge we have gained, inspiration we received, and the connection we have made, and the commitment to serve our patients with even greater compassion, skills, and the scientific rigor. I am confident this scientific event further renewed commitment to improving heart health and beyond multi-specialities. On behalf of the Cardiac Society of Nepal and myself as the president of the society, I want to thank you all once again. May we continue this journey of learning and collaboration in the years to come. Once again, thank you all for being a part of this important event. Enjoy your stay in Kathmandu, who are coming from out of Kathmandu. And I also pray for the safe travel back home and stay healthy until we meet again. Thank you and dhanyavad and good night. Maybe we are having program. Anybody wants to say anything? No. We have a dinner, so I also request on behalf of the Cardiac Society and the Sun Pharmaceutical, please join the dinner. And thank you and dhanyavad again.